Good evening, everyone. Today, I would like to discuss about shoulder MRI planning and anatomy. Basically, shoulder joint, anatomy of shoulder joint. Shoulder joint or glenohumeral joint is a ball and socket joint, joints between the scapula and the humerus. It's a major joint connecting the upper limb to the trunk. It is one of the most mobile joint in the human body. And shoulder joint is basically it's a large and complicated joint, and we use on daily basis. The joint is made up of three major bones. That is, first one is humerus, and clavicle, and scapula. This makes it the most mobile joint in the body. As a result, numerous problems can affect the shoulder. Those are basically dislocation of shoulder joint, degenerative joint diseases like arthritis, rotator cuff tear, bone fractures, sports-related injuries, unexplained pain and swelling, decreased range of motion, uh, infection or tumors, and these are the some few examples. In some cases, an MRI is the best tool to help the doctors to track the effect of surgeries, medications, or physical therapy of your like shoulder joint. Basically, there are few muscles. There are four muscles which pulls the humerus towards the glenoid cavity. Those rotate these are the few muscles which is pulling the what do you call the humerus to the glenoid cavity. It's called rotator cuff. Rotator cuff is a common name basically for the four group of muscles and their tendons, which provides strength and stability during the motion to the shoulder complex. And they are also referred as sits muscles, with reference to their first letter of their names, that is supraspinatus, infraspinatus, teres minor, and subscapularis, respectively. These muscles arise from the scapula and connect to the head of humerus, forming rotator cuff around the this what do you call glenohumeral joint. First we discuss about supraspinatus. Here you can see this is the supraspinatus. This red portion is called supraspinatus, which arises from the supraspinatus fossa of scapula, and it fits into the superior facets of great tubercle of humerus. And next is infraspinatus. Basically, this is the infraspinatus. You can see infraspinatus it's arising from the infraspinous fossa, and which attached to the middle facet on greater tubercle of humerus, which helps in external rotation of the arm. That's the main function of infraspinatus. And next is teres minor. This is the teres minor, and which arises from the middle third of lateral border of scapula, and which attached to the inferior facet. This is the inferior facet on the greater tubercle of humerus, and which also this muscle also helps the shoulder for the external rotation. And next is subscapularis, which arising from the subscapular fossa and attached to the lesser tubercle of humerus, and this also help for the internal rotation as well as the arm abduction. And next major point is femoroglenoid joint. Basically, femoroglenoid joint has some supporting structures. Superiorly, actually speaking, it's attaching to the coracoligamental arch and coracoacromial arch and coracoacromial ligament. This is the coracoacromial ligament, and it's attaching to the superiorly. There is a structure called long head of biceps tendon. This is the long head of biceps tendon, and tendon of supraspinatus muscles. These are the superior structures of what do you call glenohumeral joint. And anteriorly, this is the anterior side of what you call glenohumeral joint. And anteriorly, we can see anterior labrum and glenohumeral ligaments. That is, actually speaking, there are three ligaments. One is superior glenohumeral ligament, and next one is middle glenohumeral ligament and inferior glenohumeral ligament, and as well as you can see scapular tendon in the anterior portion. And posteriorly, actually speaking, we have posterior labrum, and as well as posterior band of inferior glenohumeral ligament, and as well as infraspinatus of teres minor. These are the structures which includes the glenohumeral joint. Next, when we move to the anterior side of anterior graphic or anterior representation side of shoulder, there are many tendons. The tendon of subscapularis. There are tendon of subscapularis that is attached to the both of the lesser tubercle as well as to the greater tubercle, giving support to the long head of biceps in the bicipital groove. Dislocation of the long head of biceps will invariably result in rupture of the subscapularis tendon. Basically, the rotator cuff is made up of tendons of that's we already discussed what are the major components of what do you call what are the major things involved in the rotator cuff. And when you move to the posterior aspect of shoulder joint, you can see the supraspinatus, infraspinatus, teres minor muscles and tendons, and they all are attached to the greater tuberosity. Rotator cuff muscles of tendons act to stabilize the shoulder joint during the movements. That's the main function of those muscles. Without the rotator cuff, the humeral head would rise up partially out of glenoid fossa. Lessening, that's a main, without the rotator cuff, actually speaking, the rotator cuff muscles and tendons act to stabilize. The basic function of the rotator cuff and the tendons are the muscles is to stabilize the shoulder joint during their movement. And when we move to the MRI planning, basically what we need to look actually when we plan the coronal, we can see we used to plan. First, we will take the what do you call the scout image, axial scout image. Actually, when we plan the coronal, it should be oblique, obtain oblique coronal plane. The plan should be perpendicular to the glenoarticular surface, and if you can see here, and it should cover anterior and the posterior part of the entire shoulder joint. And when we plan the sagittals to obtain the sagittal images, this it should be the planning should be parallel to the glenohumeral articular surface. So in coronal it should be perpendicular, and in what you call sagittal it should be parallel. That's the basic what you call planning method of shoulder joint. When we plan the axial, it's always better to include the acromioclavicular joint in the shoulder joint imaging, because most of the time patient may have shoulder pain maybe due to the acromioclavicular infection or with their pathology. So it's always better to include the acromioclavicular joint in the first axial slice. And here you can see the clavicle and so distal end of clavicle as well as the acromion scapula and supraspinatus muscle. And in this slice, you can see supraspinatus tendon, deltoid muscles, and spine of scapula. Like that, we will plan slices In this slice, you can see biceps tendon, humeral head, deltoid muscle, infraspinatus muscles, spine of scapula, all the anatomical regions, and it continues and ends with this slice. Actually, this is the basic planning of axial joints of shoulder. When we move to the next slice, here you can see the normal rotator cuff. See, you can see the tendon. It's attaching to the humerus, and this is the example. This picture represents that there is a tear in the. You cannot see the continuity here. You can see the fluid over here. That's a indication of rotator cuff tear. And this here you can clearly see that this is the partial tear of rotator cuff. This is the humeral head, like the ball of humeral head, and this is the what do you call, so rotator cuff. Here you can see the tendon there, and it's a complete tear of rotator cuff. And when we plan the coronal, actually it should be, I told you already, it should be perpendicular to the glenohumeral joint. And here you can see a few muscles and a few bones, shortcut of biceps, deltoid, coracoid process, clavicle, subscapular muscle, axillary vein and vessels, coracoclavicular ligament, all those things we can see. And we are continuing these axial slices till this is the end, because we are covering the entire shoulder joint. So in the last slice we can see the teres minor muscle and infraspinatus muscle. It's not while we're planning the MR images, it should be accurate. Actually, we should not take more number of images, because it will increase the scan time, which will result difficult to lie down in the MRI couch. So always while we plan MRI, actually we need to plan only the required slices. No, it's not good to give more FOV, and as well as actually in our institute, actually we used to image the shoulder joint with less than 100 centimeter FOV. That's the right way of because it will give good resolution as well as good clarity in the images. And next we move to the sagittal slices. I already told that it should be parallel to the glenohumeral joint, and it's this is the this is the planning of glenohumeral joint. Here you can see the infraspinatus tendon, biceps tendon, all those structures, which is just the part of rotator cuff. And but again, we need to cover the entire shoulder joint. From the distal part of humerus to scapula, the glenoid cavity. And basically speaking, the shoulder joint pain may be due to the tough, rotator cuff tear. So the MR abnormalities that we can diagnose with the MRI is first, MR abnormalities is full thickness tear. When there is a full thickness tear, it will be a high signal intensity on T2 varied images. We can see the fluid collection over there. And the direct signs of rotator cuff tear are tendon discontinuity. That's a direct sign. Fluid signal in the tendon gap, then retraction of musculotendinous junctions. These are the direct signs. And associated findings, that is subacromial or subdeltoid bursal fluid and muscle atrophy. These are the indirect signs of findings of rotator cuff tear. And basically, this is the another slide which showing rotator cuff tear. And you can see the basically it's a partial thickness tear. Here also you can see the T1, T2 increase signal intensity, and what do you call the higher signal? It will be higher signal than the muscle compared in T2. That's the major, because there is a fluid. That's the reason it's showing bright signals. And it's another picture of normal supraspinatus tendon. You can see the tendon nicely over here. This is the tendon. Thank you. Thank you very much for your patient listening. Thank you.